Welcome everyone to this APOST broadcast. We're here in Hong Kong. We have to thank the APOST group with Michael Tong and their efforts at putting together another sort of webinar. So thank you very much. And, my task today and the part that we're broadcasting as part of today's course is really to talk about frontal sinus pathologies and surgery. And this is an area that I think Professor Carney and myself really do differently than perhaps how we were trained. To talk about the pathology is very brief. To me, if you said to me, why do frontal sinus surgery? Well, we really do frontal sinus surgery for inflammatory reasons. And the inflammatory conditions that we have are localized problems in which there probably is an anatomical problem. So people who get isolated disease in one part of their sinus cavity really have just an inflammatory disorder. Really, you can do any sinus opening you want here, and it's probably going to solve the problem. Diffuse disease is a little bit different, right? We just heard Calvin speak about what we're trying to achieve. If you have someone who has a inflammatory diffuse disorder, the surgery is never going to cure their situation, like polyps. You really need to do the surgery where you've got some goals in mind, and the goals might be to remove the polypoid tissue, maybe to create a cavity that you can wash the mucus out and wash medication into it. But ultimately, patients who come in who have sinus cavities that are full of polyps, I can tell you, being in a country where we've had access to biologics for 10 years or more, now almost 10 years in our space across asthma and polyps, just simply giving people biologics or medical therapy will never make these people right. They often develop tissue remodeling and problems in their sinus cavity, and they need procedures done. But the procedure that we do doesn't cure the problem at all. And I would actually say the procedure itself doesn't do anything to the underlying inflammatory condition. All it does is help you really establish a sinus cavity that you can then treat. Now, the other place to do frontal sinus surgery is access. A couple examples here are CSF leaks. I'll show an example of this. One might be orbital access, so you're trying to get to an orbital mass or tumor or an orbital decompression. And then, of course, for tumor surgery. So tumor surgery, you have tumors that are in the frontal sinus. I think in that situation, you need very big access to the sinus cavity, like a Lothrop. And then you just need for some people to see the frontal sinus, where you've got a papilloma hanging off the ethmoid. You just want to see above it. And this is a great case for something like Carolyn's. So in that spirit, though, I only have 3 frontal procedures I do. I still leave it alone, even when it's not involved. And a good example of this would be odontogenic sinusitis. So we commonly see in odontogenic sinusitis a maxillary-focused inflammation where the frontal is secondarily involved. Sometimes we see this in fungal ball as well. Now, for many years, we've left this alone. We've spoken about it. People sometimes still like to operate on it. And John Craig wrote a really nice publication where they took odontogenic sinusitis patients, 70 of them, and 35 had an antrostomy alone, and 35 had their frontal sinus opened as well. And really, he showed that in these patients where you've got the frontal sinus involved as a secondary issue to some other localized problem in the sinus, that actually there was very little difference. The resolution at 6 weeks was 100% versus 97%. It didn't make any difference whether you did the frontal sinus or not. People came good. And perhaps the only factor they could find was at the first visit, you could see a slightly earlier resolution of edema, but at every other time point, things were similar. And it's not 22 and malodor resolution, everything else came good. So there are situations in which I just won't do a frontal sinus surgery, even though it's actually involved. And that's a case where it makes sense that if you left the anatomy alone, because the underlying inflammatory source is gone, it all settles down. So I do leave it alone, but the other one I do is that I will do some type of what we call a Carolyn's, and we're going to talk about this. A good case for this is a CSF leak. So here's a person who's got a CSF leak in their olfactory cleft. When you go up and manage these patients, you can see the CSF coming out of the sinus cavity there. And you don't know, actually, in this patient, the actual defect was much further back. And so when we're going to do these type of cases, where this is a different case altogether, you can see there's the defect. Here it is here, just there. So on the left-hand side, you can see a very small olfactory cleft, encephalocele. In these patients, when you do this type of surgery, you need to be able to see it. And the way we do the surgery is not through the olfactory cleft. You actually need to see the skull base above and behind it and below it. And you'll see here in a moment. So there's the small encephalocele, but you can't be working in that space. That space is barely, sort of 3 millimeters wide. And so for a lot of our patients, we'll simply trim the middle turbinate back to that area. You can see that we've actively opened up the frontal sinus with the carolins, and we've drilled the bone off. We've actually even got to shave the swell body out. I was just talking to someone about that. So then you've got this really nice access here. We're going to trim the middle turbinate back until we get to that skull base defect. But you can see that we've already drilled the frontal sinus, so we have this lovely access here. And so whatever repair that I'm going to do, I know that I'm not struggling with access. I'm not using angled instruments for it. And whatever repair I do here in a moment, there's my encephalocele, I'm not going to block up the sinus cavity or cause secondary sinus dysfunction when I'm simply here to repair the skull base. So you can see there's the skull base through a carolins, posterior table. Here's the defect. And now you can sort of mark off all of this. You're using a 0-degree scope. You can see your skull base laterally. You can see above and below your anatomy. Simon spoke about the anterethmoidal artery. If the anterethmoidal artery was somehow in your way here, because you've done a carolins and a frontal sinus approach, you've got very good access to this area. You could easily divide and bipolar the anterethmoidal artery. But in this situation, it's just a simple encephalocele. We'll freshen up the edge, take the encephalocele out. It's always like sending a bit of tissue off for the pathologist to demonstrate what it is. And then we'll find the actual defect. And you can see how I've got the frontal recess exposed in my outside peripheral view here. And there we are there. There's the defect. And for these sort of lesions, there's the sort of CSF space, a little bit of raw bone. We'll make it bigger. We really want to make sure we put some sort of fluid or layer into the sinus cavity. And my favorite thing here is not fat, but just to use a bit of collagen matrix. And so here we go. Here we make a little collagen plug, and then we shove that collagen plug in, and then we put a free graft on the top. But you can imagine doing all of this if you hadn't opened the frontal. You're working under shelves and roofs. It makes it very, very difficult. Doing tumors is another one. So if you have an osteoma like this, you need to really see the frontal sinus ahead of it. If you said to me, what's the rule of thumb? If the tumor gets anything close, in this olfactory neuroblastoma, to the anterethmoidal artery, then you need to be opening the frontal quite widely. Otherwise, you're really going to struggle to see the front edge of the tumor. Otherwise, you're using angled cameras all the time. So if you said to me, why do we do some sort of extended frontal opening here? You need to see above the anterethmoidal artery. And then finally, I said, I still do a draft 3 because one of the problems is in carolins, you're working in this box. So if you make a unilateral frontal opening, it doesn't matter how big it is. I think this is one that looks pretty big, looks like a giant middle meatus right up to the top. The problem there is that you're working in this very tight column where it's very hard to work laterally, very hard to work medially, and you're sort of stuck in a vertical box. And while it's great for access, it doesn't afford you much instrument dexterity in the sinus cavity. So if you see cases like this, like a big frontal osteoma, you will never, in my opinion, do this easily through a unilateral approach. You have to have a draft 3 to do it. And just as a way of noting it, this is a patient who had a simple osteoma 4 years previously. And it's just a reminder that when you see osteomas, don't ignore them. Some of them will grow, like this this person who had a small lesion 4 years previously and became a very big lesion a few years later. And so to do this sort of case, you've really got to have an open cavity. So here he is here at the end of his procedure when he's all healed. And you can see how it's very, very different to the access you get with a carolins. You've got the freedom to move laterally either side. You can work from contralateral side to the ipsilateral side, cross-cording. So this is why you need a draft 3 in this situation. So look, that's the first part of my talk, because it lays out what are we really dealing with and what surgery you need to then achieve it. So then let's talk about how we actually do that surgery. So for me, the surgical approach to the frontal sinus is, Simon talked about the box. You know, we really have this very simple surgical box concept for the sphenoethmoidectomy. There is a box to the frontal. And by the time when you connect them both up, they become the neosinus. So in the box here, say for the left-hand side, you have the middle turbinate, just as we were doing on the cadaver specimen. It's your medial boundary because it's the boundary to the olfactory cleft. You have the orbital wall, which is your laterally boundary. You have the posterior table and skull base, which is your posterior boundary. And you have a bit of the nasofrontal beak. Now, previously, when I did a lot of angled frontal work, you know, we would say, look, when you look up with a camera, you should be able to see all the limits when you finish a frontal sinus opening. And when I say the limits, you should be able to say, okay, well, there's the nasofrontal beak. In one view of the endoscope, you should be able to see the anterior limit, the posterior limit, the frontal sinus becoming the posterior table. You should be able to see the medial orbital wall becoming the ethmoid roof, or the orbital roof, I should say. And you should be able to see the middle turbinate become the intersinus septum. These are your boundaries. And really, you know, for Simon and I, you might look up initially in a cadaver or a really easy case like that, and you can say, well, this is maybe the agonasi, this is a suprabular and bular cell, and my frontal recess is going to be here. And it's possible to dissect your way through the natural pathway and end up where you want to be. But the problem there is that those anatomies just simply don't exist when there's bad pathology or there's been prior surgery or scarring and things are in your way. So if you're constantly wanting to find the natural pathway as the only way that you can get into the frontal, it lets you down, in my opinion. And so rather than worrying about the cells, we say, focus on the boundaries. Professor Carney said, you know, rather than worrying which ethmoid lamellae you're at, just say, have I connected the orbital wall from the anterior part of my cavity all the way back to the orbital apex and the optic canal? If I've removed all the partitions along that wall, then I know I've taken all the lamellae and all the ethmoid partitions. And then, of course, once you combine your Professor Carney's sphenoethmoid box with the frontal, you end up with this cavity. And the cavity really, at the end of the day, is very, very small. Like if you said to me, how big is it? It's really the size of my thumb and my index. It's amazing. There's so much debate about how to create that space, right? It's a tiny little space. Now, one of the problems in doing that cavity, though, is that when we come in to the sinus cavity, yes, we talk about removing these frontal sinus partitions, but traditionally, and we want to create an opening here that drains down into the sinus cavity, but traditionally the way we've done it is we've come in and then looked almost at right angles up, and it's required surgeons then to be stuck inside the frontal recess, working with angled instruments and angled scopes. Whereas the Carroll's window approach is just remove the bone that's in your way. I see some people do an angled instrumentation, and by the time they've used a drill and a kerosene and a baby cobra, they've spent as much time removing the bone that they could have just done at the very beginning of the case to get in there. And that's where this evolution really starts. And this is really the whole concept of Carroll's windows. It's all about making it easy, and it's importantly also about using a 0-degree scope. Now, someone said to me, oh, the 0-degree scope's great, Richard, but I've got great skills with my 70 and I can really work with angled instruments. It's true. I've seen some colleagues who have amazing ability to work with angles. But there is another part of why this is easy, is because when you do your surgery, your camera and endoscope is not underneath your instruments, where blood and mucosa and secretions get onto it. You're back, and you're doing your surgery always slightly in the distance away from gravity-dependent secretions and blood. So needing a straight instrument. Now, where did all this come from? I still like to show some of these early videos when we first were talking about doing it. So this is a patient who had a giant skull base osteoma, and he actually came back and saw us many years later because he was getting a bit of barotrauma in his frontal sinus, and we'd never really completed his frontal sinus cavity. I said, come back and see me. And I said, look, we just need to get in there. And I said, let's just remove that bit of mucosa, because all I need to do to see this guy's frontal sinus is to get rid of this. Now, many people have described this. PJ Wormwood talks about the axillary flap. Jim Palmer talks about nibbling this bone away. And I was with Carolyn Orgain, one of our fellows, and we said, look, we just need to remove this bone. And I said, let's just really take it up. Let's stay away from all our previous operation. Let's just remove this bone. And this person, it's not particularly thick, so we're into really expose the front wall of the Agonasi very easily here. But we've had to use a drill to do it, right? It's not like something you can just nibble away. And as you remove the partitions here just with a quad cut straight shaver, you can see it. And although I'm using a baby Hoseman, I'm still using a 0-degree scope. And as we did this cavity, you can see how we can see the posterior table there very, very easily. And you can actually see this cavity, which is a very straightforward cavity looking up towards the posterior table. Now, it's not even how we really do Carolyn's now. I'd say we even take a more acute angle. But it shows you what we're trying to achieve. We're trying to remove the nasofrontal beak, this area here in the procedure. And I think this is very important. So we first thought this would be a great approach for people with hypoplastic sinuses. So here's a patient who's got really, in hindsight, CCAD, has had partial surgery. And although we're doing his sinus surgery to help improve his cavity, he actually was getting barotrauma. And you can see how we've done like this Carolyn's window on a hypoplastic sinus. He doesn't have big sinus cavities. And you can see here on the contralateral side, this side's healed a little bit, but he's still got some crusting on the other side. But you can see how it's just given us a direct view up into the frontal sinus. Now, he had a not a very well numerous high sinus cavity, so doing a Lothrop or anything else is not going to work for him. And we thought maybe just doing this in hypoplastic sinuses would be a good start. And it does work very well. And we're about to do a dissection on a head that doesn't particularly have a big frontal sinus, so it'll be a good example for it. But what are we removing? We're not in the midline. We're actually partially paramidline when you're doing frontal sinus surgery. So that's the nasofrontal beak. And this is the bone that's getting in your way. Now, if you said to me, there's lots of techniques describing removing this bit of bone here, but it's this bit of bone that has to go. It's this final bit up here that gives you that access. So here we go here. Here's someone with CCAD and barotrauma. We might, shoot through this video a little bit. So here we are now. We used to just take that. This is on the right-hand side. We used to just take the mucosa off, just like I showed you on the first case. This video is very old, but here we are now just drilling that bone. And just taking away that bone just allowed us to really see that opening easily with a 0-degree scope. And you can see how my shaver and everything else is working in the distance. I'm not actually working underneath everything. And you can see there's a lot of obstructive mucus and everything else going on here. So here's the final cavity. So there's the opticocarotid recess, the corner pocket. And as you follow up here, you can see we're following it up. And this is what we used to do. So for hypoplastic sinuses, and you know what? For the most of the time, it healed pretty well. But we did get, because we were just cutting the bone off at the mucosa and leaving a bit of raw bone, we did get a situation where if you look up at where we've been drilling, you see how there's a bit of granulation tissue there? Like, it was pretty good, but there was a little bit of granulation tissue. There's a bit of granulation tissue sitting on that lateral area where we've drilled. And I was at a course one day where I had Brad Woodworth come out from the US, and he was watching me operate. He said, Richard, you've got to add a flap. He said, you just, there's no point like cutting that off and trying to do something with it afterwards. And he was absolutely right. So, what we do now, rather than just excising it, we'll preserve it. And we started off doing little mini flaps, and where we pull it all the way back. And we used to then try to just peel it away and work around that. Now, that does not work very well, I would like to say. This is a video early on where you can see me drilling now and removing this bit of bone, but I'm still got this concept that I'm trying to only expose the bone that I want to drill and nothing more. If I do that, I've made it look easy because I've actually got, and you can see there's a bit of polyp, but it's giving me good access. You'll see in a moment here, we'll remove a bit more bone. It does work very well, but I can tell you this operation, my camera is being held really still because it's sitting right next to the flap that I've raised, and it's not in an ergonomically very good position. And although I could make a video about it, I didn't like the design of this flap because it was sitting right where you want to drill and you have your instance. So yes, it sits back, but what Brad was right about is that when you did that then, and you can see this nice opening, and you returned the mucosa as a flap, so you can see right up into it, it healed really, really well. So the more raw bone that you can avoid, the better it will heal and it heals well. So of course, Brad saw me operate again and said, Richard, you're still doing it wrong. I said, you need to take the whole wall off and make a proper flap when you do it. And once again, Brad was right. So this is how we do it now. He suggested making a strip going based inferiorly. And I said to him, listen, why don't we just take the whole wall? So we take the whole wall now right up to the piriform. So you can see me finding the piriform. And we take that entire lateral wall mucosa off. And the reason I like to show you the evolution here is that we are exposing more bone now than you actually need to expose to do the drilling. But actually, the flap heals better the broader and wider it is. It gets less congested, less swollen. And so what we do now is we drill this this wedge of bone, which we call Ritter's triangle. And as we drill Ritter's triangle now, we've got way more bone exposed than we actually need to expose just to drill the sort of the beak that we're trying to get rid of. But at the end of the case, and you can see here now, we're really going this sort of vertical route here. And you can see here, I haven't even completed the rest of the frontal sinus partitions. This person has had a limited procedure already, but you can see now, only when I've finished, I can just drop the quad cut in there and get rid of all those partitions and find the boundaries that we spoke about. But the flap goes back, and now the flap really covers pretty much everything. There's still a little bit of exposed bone at the top, which we put a free graft on. But now once you combine these techniques, really using Brad Woodworth's flap, you get very little goes wrong. You can see a tiny bit of scar tissue at the apex of the nasal cavity, but everything else heals. It heals like a patient who maybe just had really favorable anatomy. And what you're doing is you're turning every patient, no matter what pneumatization or thickness of their frontal beak, into a favorable anatomy. So here's an example of how we do it now. So we've done exactly what Simon and Calvin have done already, which is to create the lower sphenoethmoidectomy. We'll do this giant, broad flap. You know, it's not actually, if you look back and look with a headlight, it's not a big bit of tissue, but you are just taking the whole lateral wall off. Now, in some people, this is very useful because as you drill out here, some people, the periosteum that you're finding is much further out than you think, and their bony contours are such that it makes the cavity really narrow. And by drilling this broad area, you actually get really good access and exposure. So by exposing all that bone and drilling it, you do super well. You're always in front of the frontal recess here. If you need to cross over and go into the beak and go midline, we'll probably have to do that in a moment. It's something that I think you just need to find the first olfactory neuron if you're going to cross medial to the middle turbinate. And you can see here, just a 0-degree scope, we're just drilling straight up. We remain essentially just anterior to the frontal recess and frontal sinus the whole time. You know, you can't go wrong unless you've actually already gone through the frontal sinus and frontal recess. So that's why it's a really safe technique. You can see I found the periosteum laterally. And we really try to drill as much as we can before we stop and then nibble away the remaining partitions or ridges as Professor Carney described. And then we'll put a little glove spacer in. We put the free graft in there, and I'll tuck that in. And I don't show my free graft going in. I hope this one does. Here's another case. So with the flaps gone back up, we'll put this sponge in, and then we usually take a free graft of mucosa from the inferior turbinate tail, but it can come from anywhere, and we'll use it to then layer that final bit of bone. And it's quite amazing when you do a mix of flaps and free grafts, you end up with a cavity at 3 weeks that really has very little raw bone at all. And I think that's one of the keys for getting people to heal well without scarring. Now, if you said to me, what are we doing when we do Carolyn's window? We're just simplifying it. We're taking the beak away, We're making the opening favorable, like someone who's just naturally born with a giant middle meatus and a giant agonasi. And Claudio gave me this matrix because in frontal recess classifications and people who are trying to talk about all the cells, a big concept they have is that the AP diameter dictates your surgery somehow and the difficultiness. Well, by doing a Carolyn's, you're just getting rid of the AP diameter. And then you're dumbing the whole matrix down just to how many complex cells are there in the recess, just to make sure that you haven't done an incomplete excision and you're still looking at a suprabular cell. So it makes it really much, much easier. And it means then you can sort of reliably produce cavities where you look in, you can sort of see up. And someone asked us about trimming the middle turbinate. It's a good example of how I trim the middle turbinate. There it is there, being trimmed. You can create a simple cavity. Here's another one. I've left the middle turbinate in place, but you can see I can look straight up into the frontal recess there. 0 degree scope, can almost look at the apex of the frontal recess. These patients down here, someone down the bottom here is a bit more of like the hypoplastic patient. And then this one in the bottom right-hand corner is someone that almost, I would say, looks like what's traditionally called a sort of a hemilothrop or a draft 2B where you've come across the other side. Now, does it actually improve the cavity? So to me, when you do Carolyn's, you're not actually doing the same as a draft 2A. So I think when we first talked about it, we say, well, let's just call it a draft 2A, but we're doing it differently. What you're left with is a slightly different sinus cavity than a simple draft 2A, because you can actually see right up into the frontal. And a couple of groups now, John Overdice did a publication once on cadavers, and then Kishorn and the Bangkok crew looked at frontal sinus irrigation. They used 8 cadaver heads, 16 sinuses, where they did a draft 2A and then a Carolyn's, and they graded the degree of frontal sinus penetration according to 3 grades. How well did irrigation really get up into the frontal? And actually, it's one of those amazing things from having done these type of studies before. Irrigation does not get into the frontal very easily, especially when there's an angled turn, like when we do 70 degree scope work. And they showed that actually in a matrix here, where they looked at the grades of penetration based on an angled down on the horizontal and Carolyn's on the other side, that the cadaver heads, and these are the same heads doing a 2-step approach, getting an angled first, then a Carolyn's, that overall, once you did a Carolyn's, you got much greater penetration in that Carolyn's group than you did previously in the angled 2A group. So it works, it helps with inflammatory and topical access, but this is really a talk about frontal sinus access. So let's have a look at this case. This is someone with an osteoma, and let's let this play out and see how we actually do this case. So here's an osteoma. You can see it's in and around the anteroethmoidal artery. So once we know that an osteoma like this is near the anteroethmoidal artery, I know that I've got to be able to get access to the anteroethmoidal artery without angulation. So I'll need some sort of extended opening into the frontal. And of course, I want to be able to see in front of this. So we've seen all these techniques now. I'll let this video play out because I think we've got enough time. I've only got a few more slides. But you can see us opening the lazy S as Calvin, or lazy L as Calvin pointed out. There's the inferior uncinate, as he spoke about, makes it easy to get with a backbiter. I sometimes tug that out, just like Calvin showed us this morning in the lab, and use an up-through cut. Sometimes I'll use a kerosene and just nibble it away. There's the bulla. Taking the bulla off is all about finding the orbit. And Calvin really showed us this concept of finding the orbit, not getting a mojo of where it is, but being absolutely certain. You can see I'm looking for the floor there. There's the floor, there's medial orbital wall and floor, almost exactly what Calvin showed us this morning in the lab. Poking straight through, as Simon Carney showed us, just somewhere between the orbit and the turbinate structures, will just be in the middle of the ethmoid cavity. Finding then the superior turbinate and the medial boundary posteriorly, voiding a tunnel down to the sinus cavity. Now, this is someone who's got a tumor, but you can see as long as we stay, low, we're going to be open. We're going to be able to open the sphenoid sinus and find the corner pocket. And all those principles that we learnt this morning will help us to find the anatomy posterior to this mass. And you can see us taking, I should have taken this, Simon, beforehand, right? I took it afterwards. And then here we are removing the retromaxilla. So I found the posterior ethmoid roof behind this osteoma. I found the orbital floor there, or orbital wall, anteriorly and posteriorly. Now we're going to go and find the frontal and the posterior table. So here's our flap. There's the piriform aperture. We'll drop it down just behind the piriform aperture. We fold this big flap of mucosa away. It's obviously exposing more bone than we actually need to remove, but it helps recovery and actually the dissection. And so as we drill this, we find the periosteum of the nasolacrimal duct. That's the first lateral limit. Up here, you'll then find the periosteum of the frontal process of the maxilla. And once you see it, that's all you need to do is expose it. Like in temporal bone surgery, once you see where the facial nerve is, you don't need to sort of skeletinize it the whole way. And then now we just drill everything away directly into the frontal sinus. And then once we get in there, we can open up the frontal sinus, still looking with a 0-degree scope. I can see the posterior table. And really, I haven't pushed it even in this case too hard, because all I need to see is just the posterior table. Now in here then is my mass. But now that I've got access above, behind, medianly and laterally, I can simply just sweep the mucosa away. There's the mass movement of the orbital wall. So we know the orbit's there, but we didn't need to know the orbit was there from movement. We could see it from this landmark, right? We found it down there. So we know that's the orbit, right? Because of how we found Calvin's floor to medial orbital wall transition. So there's the mass, front to back, above and below it. And now we can just simply drill the osteoma away. And I'm not working underneath myself. My camera is back from me. And so it's all working in the distance. If you did this with an angled scope, you'd be doing this drilling underneath yourself, and that makes it really hard as a surgeon. So eventually we just core out this osteoma. Once we've cored out the osteoma, we then will find the shell of it, and you can roll often them out. Got to be careful about not doing it too early, otherwise you get a piece that's too big. This piece is big enough. I think I'm going to be able to just squeeze it out without scratching everything up. And we'll find there's the medial orbital wall, a couple of stretched partitions from slow osteoma growth over time. Here's the sort of attachment point, and there's the remaining part of the osteoma. And then you're left behind with a very simple cavity, a lot of mucosa still intact. And of course, taking benign tumors out is not just about taking the tumor out. You've got to make sure you give them back a healthy cavity. Bit of hyaluronic gel, free graft, a spacer, and we take the spacer out at 1 week. If we use silicone sheets, we take them out at 3 weeks. And here's this patient 3 months on. And, you know, Simon, I look at this patient, even though I think she's healed well and she's great, I think the middle turbinate looks a little bit chunky. I'd probably, in hindsight, trim it back if I'd known. I think I was focused on everything else. And you can see everything's healed nicely. There's still a little bit of thickened tissue around where the osteoma was attached, but everything else looks healthy and functional. Now, one thing you don't see in this video is that we're doing this surgery at quite an angulation. So we'll see it in the cadaver head in a moment. The head's all extended when you do it. So I said before, though, that I still need to do a draft 3. So as long as you remember the steps of a Carolyn's, it's the same structured approach for doing frontal work. People have probably heard us talk about the outside in, where you expose the bone just like you do in a Carolyn's, but you really go looking for the periosteum each side and know where the first olfactory neuron is and just remove the bone in between. It really is exactly the same principles as a Carolyn, and removing this bit of bone we call Ritter's triangle to give you then the true draft 3 look. And we still use 0-degree scope, and this is my final video just to show you that. So if I have patients who have big tumors, big osteomas like this one, then this is where you cannot do this with a Carolyn's. This is where you absolutely need a draft 3. And you can see here, it's all the same steps as what we do in a Carolyn's, but we're maybe in this case going to make the lateral wall flap extend onto the septum. We mark out where we are in its anterior-inferior limit so we can sort of judge the same flap on the other side. And we're doing the sort of so-called extended flap where we're sort of trying to take some of the septal window with it. I think that's practical if the septum and the swell body on the septum is not particularly thick. If the septum's really thick, it's not worth trying to keep that septal mucosa, in my opinion. But this is a case of you always want to find the first olfactory neuron, so there it is there. And this is Ritter's triangle. I was teaching someone, so I've marked off what is the triangle of bone that we call Ritter's triangle. That's what you need to remove. Once we remove it, and we're sort of onto the other side here, we're gonna connect what is in principle really two carolins. Here's one side being done. We've done the other side. As we drill this side away, and we can see we've already done the other side, you end up having then bilateral access. And now you're just removing, I guess in a traditional Lothrop sense, you've got a camera in one side, drill in the other, and you can sort of work looking at the beak from below. And here we are here. We're straight into the osteoma. So coring out the osteoma, you can see it's going to come out in chunks. And of course, there's a bit of drilling involved to debulk it all, but you've got to make sure that it all gets debulked. Flaps go back up. And in this case, you really do need this wide exposure. We'll still use free grafts to supplement our lateral wall flaps. And you can see the difference, though, you get in a true draft 3 versus a Carolyn's. You get this nice square, big opening, putting those little grafts in. So in summary, Carolyn's window is this sort of axillectomy approach where you're just taking the beak out. It just enables 0-degree endoscope work. It makes it easy by removing the AP diameter. There's no doubt that including some sort of lateral wall flap works very well here. And it provides a really favorable anatomy, like someone who's had like a giant middle meatus. Great for those conditions. But I still do draft 3 as I've described, because you end up with this cavity that can be really narrow in Carolyn's. And draft 3 coming in, outside in, always allows you to do it quickly. You find the anatomy first, and it just makes the surgery really efficient for those bigger tumors. And if you want to go to any publications here, I'll leave these QR codes up because they really talk a couple of nice technique publications that you can get access to. And very happy we're finished in lots of time, only sort of 35 minutes. So we've got a bit of time for Q&A before we go to the lab, and happy to take any questions. Thanks very much.
Thanks, Richard. That was great. So I don't know whether online people can actually ask questions, or if I can somehow find out what the questions might be. If you can go to the maybe the viewing, please submit any questions via the Q&A box. Interestingly, I've now seen Richard's talks evolve over the years with his Carolyn's window, and since the Woodworth flaps have been introduced, you know, the healing has become a lot better. But the other interesting thing is that when you watch that Woodworth flap being created, there's several nerves being severed as that comes down. And it's interesting, there's now been a study from Japan, which I think is in press, because the anterior ethmoidal nerve contains parasympathetic fibers, as does the posterior nasal nerve. Mm-hmm. So by raising a Woodworth flap, you're actually also dividing those parasympathetic fibers to the anterior part of the inferior turbinate. So the Japanese have done not a Woodworth flap, but they've done radiofrequency to that area to destroy those anterior ethmoidal nerve fibers, as well as doing a posterior nasal nerve section. In the RCT, they got better outcomes. Yeah. So in fact, by raising that flap, you're also
doing a neurectomy. Yeah, possibly. Let's have a look at on the online. Someone said, is it possible to do Carolyn's without a drill? It is. It is possible. Like some people say, I can do a Lothrop without a drill. But the patient's anatomy is so favorable in those situations. No skill is required. You essentially you've got a beak that is already completely missing because there's giant Agenasi pneumatization. The AP diameter is massive. It's just not a challenging case. So yes, you can. If actually the pneumatization pattern of the sinuses is such that you have already lost all the nasofrontal beak through pneumatization and sinus development. So yeah, 100% you can. Is there an alternative for a silicon splint post-op? Yeah, 100%. I actually do play around sometimes with putting silicon splints into the frontal recess. Sometimes I use silicon splints on the septum if I've shaved a swell body, or I just want to make sure I don't get adhesions across the nasal cavity. Then we have, is there any role for an external approach to the frontal sinus surgery? Yeah, I think there still is. I mean, I think if you've got very, very lateral lesions where you need to do something more than just simply scrape and pick at it, I think sometimes it's good to have a lateral approach. So I think if I whatever's happening laterally in the frontal sinus recess, if I think I can't connect it to a Lothrop, then that may be problematic.
Yeah, I think routine frontal defines. I think we've all given those away just for.
I agree.
Yep.
Another approach where you make a little incision in the eyebrow and a bony opening. Not really a trephine, I guess, but a bony opening lateral to the supraorbital vessels. Very occasionally I will do to access something. But gone are the days of gull wing incisions. There's very few benign pathologies, Simon, I ever do coronal flaps for or anything else.
Now, going back to this elastic splints, the previous thing, if you go into the opposite frontal as well and you take a bit of the frontal septum off, you can actually do a single elastic splint, which straddles both sides. And it's almost like a modified version of your draft 3 splint that you published on, Richard. I think a little mini draft 3 splint that goes across both sides, elastic, works really, really well.
Yeah, I completely agree. You always you never regret putting a silicone sheet in if you have to there. Someone said to me, what I use as a spacer, I don't use nasoporeal gel foam because they create granulation and they're not firm enough to hold my middle turbinate in that medial position. So very commonly I use a Miracell sponge or some sort of cottonoid sponge, and we cover it in a glove finger just to make sure it's slippery and it comes out easily. If you just put a compressed cottonoid Miracell in there and expand it, after about 7 or 14 days, it gets sort of stuck to the patient. It's a bit uncomfortable to come out.
So
someone said about
soaked ab gel, is that presumably another? What is ab gel?
I've stopped doing all of those things. So I must say I don't really leave behind a whole lot of steroid soaked things. I really find now in my world that patients do really well from just some post-operative, perioperative corticosteroids systemically, and those who have really such bad disease that you're super worried about the healing, they're sort of in the zone of getting on biologics early on after the surgery.
So I differ. I use triamcinolone soaked Nasopore to hold my elastic in place, but it's just different approaches. Frontosinocutaneous fistula.
Yeah, that's a pretty rare condition. I've only ever seen that really in frontal forehead trauma, where people have had bits of sequestrum and bone left behind in their anterior table, and it end up discharging onto the skin and then somehow is connected to the frontal sinus. I think in that situation, you've just got to get rid of the source. In the cases that I've seen, you've actually got to get rid of the bony sequestrum and reconstruct the forehead. In people in which it's got to do with some sort of frontal sinus infective problem, if you just fix the infective problem, if they've got a contiguous fistula to the skin from pus and things draining out, it'll just go away once you fix the underlying problem.
Did you do any obliterations?
No, I hardly ever do.
No, I think that's right. It's sort of replaced that.
And I think if this person who's asking this question is thinking that somehow you'll get into the skin from doing frontal sinus work, I would say you don't have to worry about that. Most surgeons can't even get close to the periosteum, let alone get through the periosteum, through the fat, through the facial muscles, through the subdermal tissues, and then into the skin. I mean, you would have to be the world's worst surgeon to come through all the soft tissue layers without realizing it to the skin. So I think the idea that someone would do that is really in the zone of saying, I'm worried about putting my trocar in, my laparoscopy of my abdomen into the abdominal aortic aneurysm artery, I should say. That has been reported, but the lack of skill and attention to put an umbilical trocar into the abdomen and put it straight into the abdominal aorta is unbelievable.
So you do know the unbelievable case in your state where someone took out the medial canthus.
Yeah, it can happen. It can happen, but there's only so far you can train people.
I think that's right.
Practical things that you
can't fix stupid. Yes.
Yep.
So
exactly.
bilateral parts of the frontal sinus. I mean, hairline incisions. Coronal flaps.
I don't do that. What this person is talking about, orbital transposition, I do absolutely do for my skull base practice. So if I'm chasing a tumor laterally, like a proper tumor, and it's attached to the orbit and posterior table, we will very commonly divide the anterothomal artery, bipolar and divided, release the orbital periosteum and push it away and take the orbital roof off from within. And that's what the orbital transposition does. And so that does give you more lateral access.
Bulgarization, very controversial topic.
I don't do it at all. And I don't think we should be doing bulgarization, in my opinion. You don't want to bulgarize. Once you create a scar tissue between the septum and middle turbinate, you'll see people who get mucus caught around that. I think it overly occludes the olfactory cleft at the expense of maintaining the middle meatus access. I think you're much better off, Simon, to do what you're talking about. Trim the head of the middle turbinate, do other things. You can put a suture in, but don't permanently scar it, in my opinion.
And prevent lateralization by putting something to prevent the lateralization of that unstable middle turbinate. Inside out Lothrop, I don't do them anymore. I don't know if you do.
No. I think that for that person, I really don't do inside out Lothrop at all. And someone asked me about this, about, do I still even do angled scope frontal work? Yeah, I do still occasionally. Like if I'm doing barotrauma or something super simple, or CCAD, and the person has really favorable anatomy, and I don't really need a big opening, and the disease is not bad, I will break out the 70-degree scope and some baby Hoseman and a curve shaver and do a old school draft 2A, because I know that if I make any opening, it'll work well, and I don't need to raise the flap and do drilling and everything else. But that said, 90% of my practice now, because most of my patients do have proper frontal disease, we do a Carolyn's window. So it really has transitioned to that.
And your finger cots stay on how long?
7 to 14 days.
It's up to 14 days for the Maricel finger cots. And how do you estimate the size of your septal window for a Lothrop?
Oh yeah, this is really easy. So you find the first olfactory neuron. So you know that you've got to take your septal window back to just in front of that, and anteriorly, you want to mojo what it would be like to get a 0-degree instrument sort of level with the anterior wall of the frontal sinus. So if you sort of mark off where that is, that's your anterior limit of the window. So you've got a posterior limit just in front of the first olfactory. Anterior limit is a straight shot to the anterior table. And then inferiorly, you can depends on what you're trying to achieve. So if the person's got a big swell body and a high septal deviation, you might drop your window down lower and just incorporate that deformity into your window. If someone doesn't have that and you want to just do a smaller window, you can. It would perhaps be no bigger normally than the junction of the upper third and lower 2/3 of the middle turbinate. This would be sort of the loose idea about how big a window would be, but it's a variable.
You go to meetings and you almost see like a pissing contest with people saying, "Oh, that's a big septal window. I don't need to make my septal windows that big."
Yes.
Who cares? It's for access. Why would you make your life more difficult by trying to keep your septal window small?
Yeah.
Do what you need to.
On the flip side of that, though, if you don't need to make a giant one, don't make a giant one, because it is a source of place where they can get some crusting. I agree.
But
not at the expense of difficult surgery.
Materials for frontal sinus splints after Lothrop. Use silastic. What thickness?
0.5 millimeter silastic. We have this sort of standard template, the little cutout that you've seen, the sort of origami we create of it. That's on one of those publications. And it's
basically you fold it like a diamond at the front, diamond, and a V at the back, and then a little trim, and then it just goes up.
Yeah, it sits in with like a T that sits across, so it stays in the sinus. We don't suture it in. And if you go to one of our publications on Outside in Lothrop, this template's there. And really, I have to give a shout out here. It's a play on the University of Pennsylvania Liberty Bell frontal sinus silastic, and I took their idea and just turned it into something you would use in a full Lothrop rather than just a unilateral frontal.
It's also one of the Medtronic, I think, frontal sinus dissection guides that they provide for free as well. So your local Medtronic rep would have a historical copy of that if you don't.
I use corticosteroids. So in pretty much all patients, they get like a 25 milligram dose daily for 14 days, and there's a cold stop. You don't taper after short courses of 2 to 3 weeks. In patients who have inflammatory disease, we used to leave them on corticosteroids until their sinus cavity normalized. and only then did we transition them to topical corticosteroid irrigations only. That world has changed for me. So I really don't give prolonged courses of oral corticosteroids. We simply flag patients very early on for biologic care or not.
And so your old theory of needing 3 weeks because the life cycle of an eosinophil, that's gone?
Yeah, well, yeah, exactly. So well, I still give 2 weeks. Yeah. So I for that reason, I still give 2 weeks. You can't just give 5 days.
No, I'm 10 days.
Yeah.
You're 14.
Yeah, you got to do 2 weeks, I think.
But I mean, people worry about stopping steroids. I mean, one of my doctorate supervisors was Steve Durham, who's a respiratory physician, and he said, after 10 to 14 days, 25 milligrams, there is no adrenal suppression. You can completely stop that dead without tapering.
And then we better do the last one, and that's how do I irrigate the frontal sinus postoperatively? Obviously, we all use high volume nasal irrigations, squeeze bottles, positive pressure squeeze bottles. When people start asking me about, do I have any other special techniques on how I get it up there or how I achieve it? The answer to that is make your opening bigger. That is of all the information, if you said, I have to summarize everything that is said about how best to irrigate the frontal sinus, make the opening bigger. Not use a different device, put the head in a certain position. All those things are talked about, but actually they are the minor factors. The main factor is make your opening bigger.
And when do you add the methadone? When the finger cuts come out or immediately after surgery?
I do it in their first post-op visit. They've got other things to worry about. And the first post-op visit, I have a chance, Simon, to talk to them about what their biopsy showed that they're eosinophilic, talk about the importance of mometasone. But I only really use mometasone irrigations in patients with diffuse CRS or inflammatory disease. Those patients I showed today in this talk about osteomas, CSF leaks, they don't use corticosteroid irrigations. They just use simple saline.
Do you use macrolides or doxy?
Once again, I don't use those things unless I sort of know that they're in a zone of patients they're going to benefit. Macrolides I do. Usually when patients go to surgery with me, I've already got the mojo that they're on macrolides. Calvin sort of talk about the phenotype of a non-corticosteroid responsive, non-polypoid looking, purulent patient. Those patients get an ECG when they come to surgery because in the perioperative ward, I get a chance to just check them off for QT prolongation syndrome. And then they'll start on macrolides post-operatively and we just confirm it and leave them on it then. And they use it for the first 3 months continuously so that I can see remission or normalization of the cavity. And then we just drop it down to 3 times a week. Yeah. But if they haven't had the amazing complete normalization at 3 months, then we stop it. Yeah. We assume that it's not effective.
And I've had one macrolide death, where, got approval from the cardiologist, just said fine. And then another cardiologist started her on flecainide and didn't take her off the macrolide. And sudden cardiac death. Yeah,
I think that's really important to not scare people, but just remind people that when you start any medications, like any GP would, because you say that, but it could have been the GP giving a macrolide for the purposes of treating a cough or a cold and had that problem. You just got to make sure you don't have interactions that are uncommon. I use clarithromycin. Yeah, 250 milligrams once a day for 3 months. Yeah. The only thing you need to screen patients for, apart from understanding an issue of interactions, is just make sure they don't have a prolonged QT interval, because you're just setting a patient up there who would, might be at this rare risk of then bringing out that issue.
Statins.
Yeah.
Statins.
Yeah. Okay, let's go to the lab. I think we need to do it.
I'd just like to thank Richard for an excellent session. And also thank all the online participants and some amazing questions. So thanks again, Rich, and we'll move back to the lab.
Are we good? Okay. So here's the nice cavity between Calvin and Simon that they've done. And I think it looks pretty good, actually, Simon. I know you're worried you're stripping a little bit, but I pushed it back. I think it's a really nice job. So here we go. Here, there's this concha bullosa. It's been made pretty thin. Simon's nibbled a little bit of the Agonazi face so we can see better into the skull base. You can see that he's got the posterior landmarks exposed, really nice sphenoid roof, carotid, optico, you might want to turn that down, optico-carotid recess corner pocket. The corner pocket is useful because not only does it show the skull base, but it also shows the orbit, which is here, which is here, which is here, which is, we know actually is this thing. So that's the orbit as well. That's the orbit. And we know then that that can't be the orbit because the orbit's over here. So that's the orbit there. And then the skull base goes from here to here to here, and then we lose it here. But really, we need more access. So if you said to me, how do we do like the frontal sinusotomy when we're not going to look up here and do a whole lot of angled scope work? Well, we're going to make that little flap. So if we make the little flap, what we're going to do here is with my slightly, you can see it, uniquely fractured sickle knife. I didn't do that, but I actually think it might be quite useful here. We're going to make a little flap here where we're going to come down, and it looks like I'm working behind the root of the middle turbinate, but I'm not really. It's a trick on 2D. I'm actually working at the same level of the root of the middle turbinate. Now, in real life, I don't use this. I use a needle point diathermy, which cuts everything beautifully and cleanly, and there's good hemostasis. And I think we saw from the videos today that that's what we're doing. Now, as we come down, there is the piriform ridge. Can you see the piriform ridge there? So there's the piriform ridge. So we come down here. There's the piriform. Now, you want to come close to the piriform, but you don't want to come so close that you end up dropping off into the cartilage. So come close to the edge of the bone, but enough that you're still on bone. And if you're obviously using a needlepoint diathermy, it's really easy to feel that you're on the bony edge. And I just want to go through this. So here we go. We've dropped it down to here. Look where I am, guys. I'm not on the lateral wall. I'm really at 1 o'clock there. Can you see that? I'm really at 1 o'clock. I've really made a real effort. It's not like a DCR flap. It really is the whole way through. Now, when we do that, we are then going to come here, and because, and I really give a lot of credit to Brad, with talking about flaps. When you make the flap drop down like that, it does become a lot easier to dissect because you're coming from anterior to posterior. Not like the first version of the flap that I described, which was hopeless. It really just popped it all the way. And as long as you get all the way down to the bone, you can really expose it there. And you want to really drop it down so you can see this area here. Can you see that? Now, I'm not going to do a whole Lothrop here because this person doesn't have big sinuses. They've just got very small sinuses. But I am going to I'm going to show you the first olfactory neuron. So here we go here. So if you want to find the first olfactory neuron, a really good thing is to make sure you come onto the septum. And then as you dissect it back, you'll see this. You see that this vessel, this is a little emissary nerve and vein. But then as you pull it down, there it is there. So I can't push anymore because that dura is heading up into the first olfactory neuron. You do have this little nerve and vein coming forward, but that often disappears, and it's often just a venous structure. There's the first olfactory neuron right there. So you can see how far away it is, right? And then here's the little nerve endings and channels that Simon was talking about, weren't you, Simon? That somehow, we might be picking up some sort of parasympathetics from the anterothymoidal artery. Now, what I'm going to do next is I'm going to go straight to a drill. I've got it here. No, leave it. So we're going to go straight to a drill. We've got the irrigation set at 30, which is great because you need a lot of water for this. And Medtronic produce the best drills, in my opinion. The guy who developed the mechanics around the burr should be given a promotion. He really did an amazing job. But you've got to make sure the irrigation's working. And you can see here that we don't have any irrigation. So something's not quite right. So what we're going to do, we're going to come back to the pump and just make sure that as the irrigation goes into the pump, it's not pinched or crimped in any way.
Was some coming through there?
Yeah, but it should be a lot more than that. And I don't think we'd been primed as well. So let's get it. There you go. You cannot drill without fluid. Very important to be able to have the fluid there. Now, I like to then always start down here. So we'll get the see that's called irrigation. I think it wasn't primed or there was a the the shutoff switch was on. So see how I've got the periosteum of the nasolacrimal area came up very quickly. That's okay. And then here we are here on this lateral wall. Now, Calvin asked me, he said, Richard, it's a bit of thick bone, a bit of an under-pneumatized sinus cavity. How long is this going to take you? I said, just a few minutes. And I said, you'll see why in here in a moment, unless we have equipment issues. So I'm just going to run it along a nice broad front, making sure I'm not ending up with shelves or ridges or lips or anything else. Can you see how I've got the periosteum there? The white of the periosteum? So once I've got the white of the periosteum, I know that I can remove all of this up to that level. And there's periosteum. And then here we go here. And this is the other thing I get told. I said, Richard, you're a white guy and do we have the stylet? Thanks, I had it over here. It is. And that you can only do this operation on Caucasian people. And they forget that I live in Australia. A third of my patients are Asian. It's not if you think about it, it's not based by their facial features, morphology. The only people I think who maybe struggle with frontal access, if you have a very strong forehead where the forehead comes really anterior to the brow line. They're people. So here we go here. So we know where the first olfactory neuron is. This is the beak up here. And when you're drilling up here, you really just have these landmarks that you've exposed. You've got this cavity here in which you're looking in, and there's skin or periosteum. It's fair way away from skin. You've got either the middle turbinate or the first olfactory neuron telling you where you are here in this posterior medial corner. And then you just know that you're in front of the frontal recess posteriorly. And you can see here, I've really tried to keep the field broad. So when I first see people do this approach, one thing I think is very common is they just drill a tunnel up here. So don't just drill a tunnel up there. Drill this whole segment here. You can see the bit of periosteum just there.
Richard, did you change your flaps according to anatomy?
No.
Still the same flap for everything?
Same flap, same landmarks, everything. I don't tailor the flap. I just make it as broad as that anatomy allows. And you can see I've got hints of the periosteum laterally. So, and this person does not have a big frontal sinus. So everyone can see the little bit of periosteum now. See the periosteum? This is a small sinus, a hypoplastic sinus. This is the better side.
Have you had many patients with periostitis? Tenderness of the nasal bone?
No, not long term. You will, if you leave raw bone anywhere in the sinus cavity, you will have patients who have problems. Now, I want to point this out. This is Simon's. You got to drill more bone to expose less. Look at this right now, right? Yes, we've opened up this front part of the sinus of the recess here, but if you just left this and went in here and tried to like open up the sinus cavity, you'd leave all this raw bone behind. And so now what really needs to happen, you just got to commit to really opening it up properly and drilling the rest of the bone, knowing that the frontal sinus is behind you. Just be careful, someone's leaning on the table. Now, the only thing I find a little bit frustrating, the drill works amazingly well, but unfortunately, the irrigation is at the tip. And therefore, if you are drilling with the pole of the burr, like I am a little bit now, you will get it blocked. It will block up on you. Okay, here we go here. So can you see this? This is the Agonasi cell here, right? See where it ends here? Now, we are about, see that little tiny opening there? That's the mucosa of the frontal sinus because the recess is behind this Agonasi. So it looks like you've got a lot of bone, like when you do a canalplasty, but very quickly, it's just going to disappear. See down here? See the blue is coming up? And I'll just poke it through. Thanks very much. And Calvin, we're about a minute away from being done.
Pending technical issues, as you said.
Yeah. So, Agonasi, we've entered the frontal recess now. Can you see that? I'll use the equator of the burr because it's a lot more efficient than the pole. And Simon's drill more to expose less concept. Equator of the burr. Get this edge off. And I still put a baby Hoseman in and things just to get the lip off.
The one shot, as Jim Palmer calls it.
Yeah, I love the baby Hoseman. Fantastic.
I see. They've banned me from having baby Hosemans because I've destroyed so many. So they've now given me the big ones, which are more difficult to get in, but they're almost indestructible. So,
yeah, fair enough. You need to drill more, Simon.
Yeah, you're right. That's where I like the upturned kerisons. So this is where if you've got those slow upturns, 2 millimeter kerisons, they're beautiful for taking away the beak.
Now, what I'm searching for here is the intersinus partition. And the anterior table. There you go. It's the apex of the frontal sinus and the front wall. Okay, now we've got a bit of frontal recess. Could we put the shaver on, thanks? Oh, I'll take that from you then. Could we put the shaver on and we'll just get rid of the frontal sinus recess partitions. So thanks, you do have a baby Hoseman. This is the baby Hoseman. It is my favorite instrument for the frontal sinus. And sometimes you can feel a little bit of a shelf here. Not much. I think I'm flush, Simon. And we'll go back to the shaver here in a moment. Can I have a kerosene up, thanks? Can someone turn this sucker on? Don't worry about it. Can you? Is it working? Don't worry about it. It's all right. I got no. Leave my sucker on. Sorry. Don't. Yep, kerosene up. So this is the nice part about doing frontal recess surgery, right? Look where I'm doing it. I'm doing it from here. Look where my scope is, right? My scope is not near the system, right? You could maybe take a little tiny bit of bone, but we're very close there to being where we want to be. So the middle turbinate is our medial boundary. The orbit is our lateral boundary. This is the skull base, which is posterior. And so anything that's in between needs to go. Yep.
So in a complex frontal recess, there could be Coon 1, Coon 2, Coon 3, supraorbital ethmoid cells, all these fancy names. As we said, who cares? They're all going.
Yeah, exactly. They're just partitions in my box. And because we got a tri-cut, it's going to block terribly. No, wait, stopped working. Give me the irrigation.
So I think at the end of
make sure the irrigation's working.
End of the last talk, there was a question online which we never answered. What happens when you leave one or two cells behind and you get a recurrence? Do you revise the surgery or do you put them on biologics? If you're using the principles we taught you today of the box, and you've got your medial wall, your lateral wall, your skull base, your orbital, your orbital floor, maxillary roof, you're not going to leave
Calvin, or just let me swap it.
What can you leave a cell if you didn't clear all your boundaries? There's nowhere for the cells to actually be missed.
Just go back to what we had. Just turn on what we had before. That's all right. Just turn on what we had before. Don't change it. Don't cut one off that's working. Yeah, all good. So all good. Here we go. Okay, so we've just got a little bit of equipment issues here. But you know what? You can see it here, Simon. I'd love a shaver to help me tidy this up, right?
Yep.
But we can do it with hand instruments. No big deal. And you'll see by the time we just take out these little partitions, it's not as mucosally preserving when you use hand instruments, nor as efficient. So that's why we love the handpiece. It's actually, guys, I think it's the handpiece is just stalled. You just need another handpiece.
You burnt it out again?
Yeah, exactly. So here we go here. Yeah, you know where it is? It's in the I don't care location. Because we've seen from the anatomy and the CT, it's not in the ethmoid cavity.
That's right.
No, seriously, that's how you should treat the location of the AA. If you can see that it's in the skull base, on the skull base, in a canal, that's it. You move on. When you read a scan, there's only one thing you need to know. Is there going to be a structure in my box that I cannot predict will be there? And there's only 3 structures that can sit in the box. The artery, in 15% of people, orbital contents from some previous prolapse or trauma or developmentally, or there's part of the brain from an encephalocele or prior trauma. You cannot predict whether the brain, the eye, or the artery will be in your box without a scan. But once you know that none of those 3 things are in your box, you don't worry about it. And there you go. And there you go. So we tidied up then the rest of the sinus cavity. We now have the suction back. Thanks.
It's interesting. We're going to have a sphenoid talk later on, but the sort of the general thing is, if you're looking into a cell which you think is a sphenoid, and you can't see a carotid, and you can't see an optic nerve, and you can't see an opticocarotid recess, there are some hyperostotic sphenoids, but if there's nothing hyperostotic or jumping up and down on your original scan, if you can't see those structures, you're not in the sphenoid.
And here you go. You could finesse this, don't you agree, Simon? You could trim this little bit back if you wanted to, but this is your box. optico-carotid recess, the corner pocket, orbit coming all the way through. You could finesse a few of those partitions. I've got some rubbish here that we could come out with a shaver. The skull base goes from here all the way up. And we've got, with a 0-degree scope, a really nice view into the frontal sinus with the apex and the anterior wall in a hypoplastic, ethnically Asian cadaver in which it's all possible. Yeah. Yeah, there you go.
Thanks, Richard. So the other interesting thing, you saw that sort of middle turbinate. You see how it sits so anteriorly once you've done a Carolyn's window, and then the top part. There's something which we've not had time to discuss today, but if you remove a little bit of bone from that middle turbinate, you can then divide through the mucosa and actually use a bit of that anteromedial middle turbinate as a flap to come over and partially cover that medial bit of bone as well. If you're doing a full draft 3, it doesn't work because you've got, it all opens up, but you can do a middle turbinate flap as well to help minimize the size of the turbinate graft.
And then someone asked me about, using the gel. I'll just show how easy the gel is to actually put in. So it's not essential, but it's just a great extra tool for, there we go.
This is the Pure Regen.
The Pure Regen. So it comes with an applicator that I don't particularly like. It's way too long. And
so you're going to cut the applicator.
It's a bit thick.
Minimize the dead space.
Exactly. It's wasteful too. Exactly. So here we go here. This is it here, where this is a curve. And I like to put it in. And so I'll put my free flap here, and then I'll fill this whole cavity with gel. On all the raw surfaces. And then I'll put my sponge in, and then the free graft sits over here. And then even if I've got a little bit of gel left over, I'll even run it in this area, because you can see from some of my videos, occasionally you get little scar webs in that area. And then that's placing the gel. And it's just a super easy topical treatment to add. Keeps everything moist, supports your flap a little bit. And then it's because it's behind your spacer, it doesn't really get washed out until you start taking the spacer out. Yeah.
And
amazing.
It looks very nice. And the when you look at the gel, 10 days, it just sucks out quite nicely. The only disadvantage of the Pure Regen is you can't add steroid to it. Makes it too loose. It just doesn't hold if you add anything to the Pure Regen. But I don't know what the price is in Hong Kong, but it's very reasonably priced in Australia.
Are there any other questions about it? Anything else? Yep. And that was a great example of, like, I didn't really, as Simon said, I didn't really go looking for where exactly is the frontal drainage pathway. It's a lovely academic exercise to do, but in patients who have serious pathology of their frontal recess or revision surgery scarring, it doesn't help you get there.
And likewise, you can see you don't need image guidance. You're just going across basic principles. You're never going to get into trouble. Okay, we'll quickly grab